Thank you, Darren. Good evening, everyone, and welcome one more to this joint EUROGEN ERNICA webinar series. My name is Sara Roman, and I am one of the project managers for ERNICA. So before I hand over to our speakers today, I would like to take the opportunity to tell you a little bit more about the European Reference Networks, or ERNs. So as the name indicates, the ERNs are networks of hospitals and patient organizations across Europe that work together for patients with rare and complex diseases, as well as their families and healthcare professionals. So they do this by pooling expertise, knowledge, and resources from all across Europe. The European Reference Networks were established by the European Commission in 2017. There are 24 of them, and each focuses on a specific rare and/or complex disease. So today, two of these ERNs have teamed up to bring you this webinar. These are EUROGEN, the European Reference Network for Rare and Complex Urogenital Conditions, and ERNICA, the European Reference Network for Rare Inherited and Congenital Anomalies. So the webinar today is titled Hirschsprung's Disease and Inflammatory Bowel Disease, and will be presented by Dr. Alessio Pini Prato, Chief of Pediatric Surgery at the Umberto Bosio Center for Digestive Diseases in Allesandria, Italy, and Professor Tomas Wester, Professor and Senior Consultant Pediatric Surgeon at Karolinska Institutet and Karolinska University Hospital in Sweden. During this webinar, they will discuss background information on Hirschsprung's disease, including a surgical procedure and a common postoperative complication, Hirschsprung-associated enterocolitis. They will also discuss the unicentric cross-sectional observational study that was aimed at describing the phenotype, genotype, pathology, and metagenomics of all patients with total colonic aganglionosis and Crohn-like lesions. So this webinar is aimed both at healthcare professionals and patients groups and has been supported by EUPSA and the ERMnet. So without further ado, I'd like to pass the floor to our first presenter, Dr. Tomas Wester. The floor is yours.
Now it should work. So thank you very much for inviting me to this webinar, which is, as you said, a joint webinar between the EUROGEN and the ERNICA. And the topic is on Hirschsprung's disease and inflammatory bowel disease. And I have no disclosures. Hirschsprung's disease is, as most of you know, a developmental defect of the enteric nervous system, which is characterized by the lack of enteric ganglion cells in the distal hindgut, with a birth prevalence of approximately 1 in 5,000. And there is quite a significant male to female ratio or preponderance, which is usually described to be 4 to 1. It's common to have associated anomalies in patients with Hirschsprung's disease, which have been reported in approximately 35% of the patients. And it's also well known that many patients continue to have bowel function related symptoms, also beyond childhood, also in adult age. I think one of the topics today is to discuss not just inflammatory bowel disease, but Hirschsprung-associated enterocolitis, which probably has a relationship with inflammatory bowel disease, which occurs in these patients. And Hirschsprung's associated enterocolitis is the most common life-threatening complication of Hirschsprung's disease. It has been reported to occur in approximately 35% of the patients postoperatively, but the incidence rate of enterocolitis has been very different in different centers, and I think that depends mainly on different definitions of what enterocolitis actually is. One definition which I think we often use is that enterocolitis should be clinically suspected in the presence of diarrhea, which is explosive and foul-smelling. And there is also a score which has mainly had perhaps significance when it comes to doing research, which was described by Pastor and a group of people several years ago. Originally, there was a cutoff at having 10 of the criteria described by Pastor, but probably the cutoff at 4 makes more sense. So this is one idea about how enterocolitis could be defined. And the focus of today's webinar is not just on enterocolitis, but also on inflammatory bowel disease, which has been shown to be more common in patients with Hirschsprung's disease compared to controls. And the inflammatory bowel disease in this context means Crohn's disease and ulcerative colitis, which are lifelong conditions that often begin in childhood. And IBD has potential negative effects on growth and development, but also on psychosocial functioning and overall well-being. And the key management strategy is to achieve sustained control of intestinal inflammation and to monitor for potential complications of disease and side effects of the therapy. I think the first publication I have come across which describes Hirschsprung's disease associated with inflammatory bowel disease is a large review of 880 patients who underwent Swenson procedure, which was published by Sherman and Dr. Swenson, where actually in the discussion there is a brief sentence describing that 9 of the patients in this series had Hirschsprung's disease and also inflammatory bowel disease. Then there are several other publications indicating that there is a relationship between Hirschsprung's and inflammatory bowel disease. This is one of the early descriptions of this, where a group from Finland and North America described 8 patients with Hirschsprung's disease and inflammatory bowel disease, where they described that inflammatory bowel disease occurred 4 to 21 years after the surgery for Hirschsprung's. And in this series, it was common with patients who had Down syndrome. 3 of the 8 patients had Down syndrome. And they also noticed that a significant proportion of these patients had chronic or recurrent Hirschsprung-associated enterocolitis. A bit more recently, Professor Puris' group did a systematic review where they looked at the association between inflammatory bowel disease and Hirschsprung's disease. And they actually found 63 patients described in 14 case series. And in this publication, it was shown that 46 of the patients had Crohn's disease. And they also noted that as much as 86% of the patients had total colonic aganglionosis or long segment disease. This is an even more recent study, which is from 2021, and it's actually register-based data from Canada, where they looked at 716 patients with Hirschsprung's disease and found that 18 of these patients actually had inflammatory bowel disease as well. And they described that this meant a risk ratio which was 12, so the risk was increased by 12 times in patients with Hirschsprung's disease compared to the controls. This group also noted that Crohn's disease was much more common than ulcerative colitis in the group of patients who had inflammatory bowel disease associated with Hirschsprung's disease. Actually, we did a few years ago a similar study using registers provided by the Swedish Board of Health and Welfare, where there is a register called the patient register, where all inpatients are registered from 1964 and on, where we found 739 individuals with Hirschsprung's disease that we compared with 7,319 patients. And among the patients with Hirschsprung's disease, there were 20 patients who had inflammatory bowel disease compared to 41 among the 7,000 controls, which meant an increased risk in the Hirschsprung population of 5 times increased risk. What was quite interesting to see in this study was that the first IBD diagnosis occurred at approximately the same age in Hirschsprung patient as in the controls. The Hirschsprung patients were 19 years when they got IBD compared to the controls who were 21 years old. Also in this study, it was more common to have Crohn's disease compared to ulcerative colitis. and there was a significant difference comparing the Hirschsprung patients and the controls when it comes to distribution between Crohn's disease and ulcerative colitis. As you saw in one of the previous slides, is that it has been indicated that perhaps patients who have Hirschsprung's and Down syndrome have an increased risk for IBD, and we couldn't find this in our register data, where just one patient had Down syndrome and Hirschsprung's disease and also IBD. Actually, these Swedish national registers, which are population-based registers, are very good because they contain a lot of important information collected over many years. One of the limitations with these registers are the lack of some detailed data. So what we actually did was that we were able to look into the medical records of 18 of these patients with Hirschsprung's disease and inflammatory bowel disease that we found in the registers, and there we could show, which was also shown by the other authors, that it seems to be common to have long segment disease or total colonic aganglionosis in patients who have Hirschsprung's and inflammatory bowel disease. Again, the median age at inflammatory bowel disease diagnosis was 21 years. And also it was possible here to verify that most of the patients actually did have Crohn's disease. It was more common than having ulcerative colitis. What we also could see when we looked into the medical records was that approximately 28 or 30% of the patients who had Hirschsprung's disease and inflammatory bowel disease underwent surgical treatment for their inflammatory bowel disease. One of the most recent and also one of the largest studies looking into the association between Hirschsprung's disease and inflammatory bowel disease is this retrospective review, which is from 17 North American institutions, and patients were collected between year 2000 and 2021. And the group found 55 patients with Hirschsprung's and IBD, where again 50% of the patients had long segment disease or total colonic aganglionosis, and 18% had trisomy 21, and also a large proportion of the patients had Hirschsprung-associated enterocolitis. They also described that Hirschsprung and IBD can be found in patients who are quite young, but it often occurs many years after the pull-through surgery. And this group also discusses treatment of IBD in patients with Hirschsprung and shows or found that the most effective pharmacological treatment is biological agents. This has been questioned in some previous studies where biological agents has been reported to be not as good in patients with Hirschsprung as in patients without Hirschsprung's. Again, this group, like we, could show that approximately 30% of patients with Hirschsprung's and IBD require surgical treatment for their IBD. So what is the relationship between Hirschsprung's and IBD? Well, looking at the pathophysiology of IBD, this is a quote from a quite recent paper where it says that it's thought that IBD results from an aberrant and continuing immune response to the microbes in the gut catalyzed by the genetic susceptibility of the individual. And this happens to be quite similar to how the pathophysiology of enterocolitis has been described. This is again a quote from a quite recent paper saying that recent advances in our mechanistic understanding of enterocolitis have focused on mucosal immunity, the role of intestinal microbiome, and the role of genetics in determining disease phenotype. And I think that in some way enterocolitis contributes to the development of inflammatory bowel disease, which also this study shows, where IBD immune markers were looked at in patients with enterocolitis compared to Hirschsprung's patients without enterocolitis, and where it was shown that the levels of ASCA and the levels of outer membrane porin C were significantly increased in patients with Hirschsprung and enterocolitis compared to patients without enterocolitis. And this pattern is very similar to what is seen in patients who have Crohn's disease as well. I mentioned the microbiome, which is significantly relevant in the pathophysiology of inflammatory bowel disease. And this is a long list from a gastroenterology paper describing alterations in the microbial composition and also microbial function in patients who have inflammatory bowel disease. And it has been studied quite thoroughly. There are several publications looking into the microbiome also in patients who have Hirschsprung-associated enterocolitis. And we were involved in a study together with Philip Frickman from the United States, from at the time Los Angeles, where we looked at 18 patients with Hirschsprung's disease, 9 of whom had enterocolitis and 9 who didn't have enterocolitis, where we examined fecal samples, and where we on the left-hand side could show that the composition of the microbiome was significantly different in patients with Hirschsprung's disease-associated enterocolitis compared to patients without enterocolitis. On the right-hand side, it's quite small, but those figures actually look at the microbiome, so that the fungi in the bowel, and where it was also possible to see that there were not just differences when it comes to bacteria, but that also the composition of fungi in the gut was different in patients who had enterocolitis compared to patients who did not have enterocolitis. Finally, there are genetic factors involved in the pathophysiology of inflammatory bowel disease. And there are at least 200 genetic variants that have been selectively associated with Crohn's disease and ulcerative colitis. And it has been described that these variants actually explain approximately 20 to 25% of all IBD cases. And as you know, there are mutations described in Hirschsprung's disease in a long list of genes. As you know, mutations in the RET gene are the most common mutations. Actually, there is limited data when it comes to the impact these mutations have on the phenotype in relation to enterocolitis. There is some knowledge about this where Martin Lacher and his group looked at NOD2 variants, which are associated with Crohn's disease, but they looked at this specifically in patients with Hirschsprung's associated enterocolitis, but couldn't find a relationship, and couldn't find that these mutations predisposed to enterocolitis. So to conclude, my take-home messages are that persons with Hirschsprung's associated Hirschsprung's disease have an approximately 5-fold risk to develop inflammatory bowel disease compared to controls. And Crohn's disease seems to be more common than ulcerative colitis in patients who have Hirschsprung's disease. And patients with Hirschsprung's disease and inflammatory bowel disease often have long segment disease or total colonic aganglionosis. And as you have seen, there are a lot of similarities when it comes to pathophysiology in Hirschsprung-associated enterocolitis and inflammatory bowel disease. And some studies have also suggested that a history of recurrent or chronic enterocolitis predisposes for later inflammatory bowel disease. But the exact relationship between Hirschsprung's disease and inflammatory bowel disease is not fully understood, and it likely involves complex both genetic and environmental factors. So thank you very much, and I'm happy to take any questions at the end of the webinar. So please, we can switch to Dr. Pini Prato. Thank you.
So thank you, Thomas, and thank you, Darren, and thank for the invitation to present this joint webinar. And good evening, everybody. I will go through this presentation that was perfect by Thomas, because he addressed most of the aspects that led to our study that we did in an eccentric series of patients who were addressed for inflammatory bowel disease and Hirschsprung's in terms of association. Me either, I have no conflict of interest, and these things have been already reported by Thomas, just to underline that the majority of the patients who have been reported to have the association of IBD and Hirschsprung are patients with total colonic, that the average reported incidence of inflammatory bowel disease and Hirschsprung's disease is 2.5%, with the worst survival and quality of life, and that most of these patients suffer from Crohn's disease. Just to mention, we started wondering if an association of inflammation of the gut and Hirschsprung's disease in roughly 15 years ago, when we performed our first study of endoscopy, lower GI endoscopy in patients with chronic diarrhea, mimic and enterocolitis. And that time we detected one patient with IBD and total colonic aganglionosis. So based on the available literature and on our previous provisional data, we decided to perform a study aimed at addressing the prevalence of IBD-like intestinal lesions. And I'm talking about IBD-like because I'm not reporting patients with defined IBD diagnosis, but we want to address the prevalence of lesions in those patients with total colonic aganglionosis. And we try to address both clinical features, molecular genetics, histology, and metagenomics of these patients. So to achieve this goal, we performed a single-center cross-sectional observational study with a prospective enrollment of patients with total colonic aganglionosis only, all patients no carrying without a stoma, and all patients who received a pull-through at least 6 months before enrollment. And in all those enrolled patients, we deliver vials of fecal calprotectin and occult fecal blood test in order to screen inflammation. We delivered a modified Crohn's disease pediatric activity index clinical questionnaire and the RNA stabilizing medium for metagenomics, both to the patient and the caregiver. And as all those patients that have been followed up and that are being followed up in our center have a phenotype and genotype assessment, we also involved in the study their complete phenotypization and genotypization. And in those patients who tested positive to fecal calprotectin and occult fecal blood, we performed lower GI retrograde ileoscopy. In order to better clarify what we defined as cases, we defined as cases all patients who carrying inflammatory lesions with were positive for histological signs of chronicity or activity of inflammation according to the definition from Patil and Oath, and controls those patients who tested negative to both fecal tests, or those patients who tested positive but were negative at histological assessment after endoscopy with regard to chronicity or activity of inflammation. So coming to the results, in a 2-year period, we enrolled all patients with total colonic aganglionosis who were being followed up in Umberto Bosio Center for Digestive Diseases in Allesandria, Italy. 14 of them were excluded due to the presence of a stoma, due to the refusal to participate to the study, or because they were died at the moment of the study. And so we ended up with 14 patients who had fulfilled the criteria for enrollment. 10 of those patients dropped out because they withdrew the consent after having been enrolled, because they refused to perform the endoscopy regardless of the positivity of fecal tests, or because they did not comply to the observational study. So when focusing on these 38 patients, we observed a male to female ratio that was lower than the 4.4 to 1 that was reported before by Tomas, but this was expected because we know that the male preponderance is lower in patients with total colonic, so this ratio do represent the reproducibility of our series. The median age at pull-through is around 1 year, which is quite common in all series, with the median age at enrollment of those patients, which is 11 years, and a time span between pull-through and enrollment of around 9 years. The family history for Hirschsprung's disease was reported by nearly 30% of our patients, without a family history for IBD in any of them. The prevalence of RET mutations and variants was over 40%, and this is again a datum which resembled the well-known data focusing on total colonic. Most of patients received an endorectal pull-through, either a Soave or a Bole or a dilatory or a Georgeson procedure. And more than 65% of the patients reported past episodes of enterocolitis. So we screened all these 38 patients with fecal tests, and 50% of them tested positive to at least one of these tests. So these 50% patients underwent retrograde ileoscopy with biopsies, and in 14 of them, with a prevalence of 37% and a confidence interval of up to 50% of the patients proved to have IBD-like lesions, with a median age of 13 years and range between 1.5 and 24 years of age. I want to underline that in 3 patients, fecal calprotectin was negative, and that in 6, occult fecal blood was negative. Of course, based on the methodology we choose at the beginning of the study, we do not screen patients with both testing negative, and so we do not know if any of these would have lesions resembling IBD like in these. And these are the appearances of retrograde ileoscopy with multiple ulceration, either scattering and rare or sparse, or confluenting into wide areas of inflammation that, as we could observe in patients who underwent a duodenal procedure, do preventively involve the ileum and seem to spare the rectum. So those lesions do mostly involve the ileum. And these are other pictures showing how this lesion can be bleeding and therefore lead to symptoms related to bleeding and iron deficiency, or can be circumferential, maybe leading to strictures or obstructive issues. When coming to pathology, we could underline that 11 of these patients had Crohn-like lesions and 3 eosinophilic enteritis, and as you can understand, the preponderance of Crohn-like lesions is evident, with coming from left to right and from up to below these pictures, an increased eosinophilic infiltrate, basal plasmacytosis, neutrophilic infiltrate somehow aggressive in the lamina propria, and complete derangement of the mucosal lining. When coming to demographics, and mostly when we compare patients with lesions and without, we can understand that there are no differences, and there are no difference in type in terms of the type of pull-through that have been performed, or in terms of the pre-assessment enterocolitis status. Either the prevalence of RET variants, family history, or other issues seems not to differ comparing patients with lesions and those without. And when coming to the questionnaire that I addressed before, the Crohn's disease activity index, pediatric activity index modified questionnaires, we could observe that both cases, both patients with lesions and without, do not show significant difference in terms of symptoms or clinical behavior, but the requirements for blood transfusion and of rectal bleeding reported by the patients. Those are on the verge of significance, and even blood transfusion, when we apply correction for multiple testing, would become less than significant. But anyway, this shows us that one of the most important issues related to these lesions seems to be bleeding and blood loss. When coming to metagenomics, as I told that at the very beginning, we addressed not only the patients, but also the caregivers, as we thought that maybe the environment could play a role in determining and increase the likelihood of inflammation. But we could observe that the abundance, the biodiversity, and the composition of the stools of controls of caregivers from patient with and without lesion does not differ. Therefore, the environment seems not to play a role. And on the other hand, we could demonstrate that the microbiome of patients with lesions is different from that of patients without lesions, with a reduced biodiversity and an increased incidence of pro-inflammatory bacteria, such as the proteobacteria, as you can see in this picture over here. So at the end of the day, the take-home message is that in this, that represent the largest series of patients with total colonic addressed on this regard, up to 50% of our patients will develop IBD-like lesion. That makes the likelihood of developing IBD lesions around 20-fold higher than previously expected. On the other hand, there are no specific symptoms, risk factors, or biological biomarkers that would allow us to detect in advance patients with inflammations. We do not know if fecal calprotectin or whole fecal blood can be used to detect patients with a likelihood of having inflammation, as we did not check those patients without with both testing negative, but this is a matter of methodology that might be we will improve in future studies. That perhaps reduced biodiversity and overabundance of pro-inflammatory bacteria may have a pathogenetic role, as Thomas was saying before, by triggering an abnormal immunity to stimulate this deranged immune response in patients with IBD-like lesions, with maybe eosinophilic infiltrate that may represent a sort of early biological marker. And in fact, those patients with eosinophilic enteritis are the youngest in our series. So maybe this is an early marker, but we still need to dig in depth on this. So at the end, we now can only firmly suggest to perform retrodialoscopy in all patients with total chronic aganglionosis who underwent an neonatal pull-through, regardless of the surgical techniques used to perform the pull-through, and to stress the importance of future multicentric studies to address this issue in details and to answer to many questions that we raised with this study. I want to say thank to the support of our colleagues that do participate in the Umberto Bosio Center for Digestive Disease, and I'm very happy to answer any question that you will do today. Thank you so much for your attention.
So, sorry, Alessio and Thomas, can you see the question I put into chat?
I see one question, which is, what is better, ileoanal or ileorectal anastomosis, isn't it?
Yeah, that's it.
Okay, Thomas, please.
Well, I think, like, if we discuss total colonic aganglionosis, I think like in rectus segment Hirschsprung's disease, at least we are doing ileoanal anastomosis, and I think that's something we do with, which is like, it's not ileoanal but coloanal anastomosis in rectus segment Hirschsprung's, but I think we are used to that kind of anastomosis. On the other hand, I have some experience years back when we did the Rehbein procedure, and some of those patients who had done an ileorectal anastomosis did surprisingly well. But we do ileoanal anastomosis, and we do a straight anastomosis. We don't use a pouch.
Yeah, I do agree. We do either perform straight ileoanal anastomosis, but when we address the difference in terms of the likelihood of having lesions or complications in terms of inflammatory bowel disease, we did observe that there's no difference in terms of the procedure done for a pull-through. The numbers are, of course, too small to draw a conclusion, but it seems that the chosen procedure, if it is done properly, does not impact on the incidence of inflammation. Thanks.
The next question is, as microbiome is noted to be different in patients with Hirschsprung and also with frequent enterocolitis, what is your opinion in the use of probiotics in patients with Hirschsprung, particularly for those with frequent enterocolitis without other mechanical obstruction noted? You start, Alessio.
But in our practice, in the past, we did a randomized trial with the colostrum to assess if it could, which is a probiotics, which assessed if it could protect from developing enterocolitis, not in total colonic, but in all Hirschsprung patients, and we did not come to evident protective effect. So other studies addressed this issue in literature, and even other studies prove that it is fascinating, but unfortunately it seems not to be protective. It won't harm, so it may be tried, but I'm not sure if the evidence suggests to use it on a regular basis.
I think we have a similar approach. We used to recommend probiotics several years ago, but as you say, I think the evidence is very weak, and currently some parents use it, but we don't really propose that, I think.
There's another, yeah, okay. The pathophysiology much more complex than an overabundance of pro-inflammatory bacteria or an altered immune response. So can you think of other potential factors in Hirschsprung contributing to the onset of IBD? Please.
Well, I think we don't know enough about the genetics in Hirschsprung's. I think there are a lot of information in genetics which we have to look further into. I think some patients with Hirschsprung actually are more susceptible than others to inflammatory lesions. Also, I think there is a lot of things we don't really know about the alterations in the immune system in patients with Hirschsprung, which also has, or immune response in patients with Hirschsprung, which also is important.
Yeah, and I agree there's something more, and I always talk about the triggering effect of bacteria over abnormal immune response. But since we try to deliver all the drugs that we are using in IBD in patients with Hirschsprung and IBD-like lesions, we observe that they do not respond as well as patients with Crohn's disease, for example, that do respond. And therefore, we are still trying to understand, as Dennis correctly pointed out, which is the correct pathophysiology. And we do not know if in patients with poor symptoms, if they will need anything, because maybe this is a sort of adaptation of the ileum that is trying to hold up the stools. So we have now done this sort of epidemiological assessment, but we will need to dig more regarding the pathophysiology and to find better treatments if there are, because now treatments on this regard is very poor.
The next question is on treatment, which is what you actually just described. I would just like to say that in our center in Stockholm, we haven't screened or scoped patients on a routine basis, and we have very few patients who actually do have this kind of inflammatory lesions. And as we did show in our study, many of these patients have their first or the IBD diagnosis when they are a bit older, and they are seen by adult specialists, I think. As you say, some people have reported that the effect of biological agents like that we usually use for Crohn's disease are not that good for these patients. And I don't know if you want to, I think that it's a very interesting discussion whether this is actually Crohn's disease or if it's a specific entity which has something to do with enterocolitis and the fact that patient has Hirschsprung's disease. I think it's a difficult question to answer.
When I brought the slides of the biopsies to our pathologist, he said to me, "This is Crohn, but no more than this." Then we addressed more in details this entity. We understood that this is a Crohn-like lesion, but as I said before, we are now using the same drugs as we do use in Crohn's, but the exact differentiation of a complete Crohn's disease or a Crohn-like lesion is yet to be solved. I don't have an answer on this. I apologize. So the next question is there any role for histopathology of appendix? Thomas?
Well, I think going back to literature, there used to be recommendations to use histology of the appendix to look for total aganglionic, total colonic aganglionosis. We don't do that. I think it's not really reliable. But so we take biopsies from the colon, from the cecum, from the ileum, but not from the appendix.
Yeah, the same for us. So I would say exactly the same.
And the next question is, at what age it's advised to perform an ileostomy? And I suppose that perhaps means in patients who have inflammation later on, because in patients with total colonic aganglionosis, we do it very early on when they present with symptoms and we have the diagnosis or they have clinical reasons to have an ileostomy. Well, I don't have any experience actually with ileostomies in this group of patients, but I think you could discuss or the indication should be basically the same, I think, like in other Crohn's patients or other patients with inflammatory bowel disease.
Yeah, I mean, out of those 14 patients with Crohn-like lesions, only one required to have an ileostomy that changed completely her life. And therefore, we now decide this on a patient basis. We tailor the treatment to each patient's requirement. And so I wouldn't say that there's an exact age, but usually before puberty, because otherwise they won't start puberty, we need to decide if to do something or not. And then there's another question. At what age do you propose to start lower endoscopy? And I mean, this is one thing that we need to address in the multicentric study, because now the patient with a shorter time span between pull-through and detection of lesions is 1.5 years, but they had only eosinophilic enteritis. Those with Crohn-like lesion has got 4 years of age. Therefore, now we would say in an empiric way, let's start after 4, but we will need to do a multicentric study to address this issue.
So what about fistulizing disease or Crohn-like disease incidence in patients with Hirschsprung's disease? Do you have an experience? Did any of your patients have a perianal disease?
Yeah, one is that one that I talked about that received an ileostomy, and I've got another couple of those with minor symptoms, fistulizing disease, but not huge fistula, and therefore they cope with it with local treatments and without the stoma. I don't think it's exactly the same as a Crohn's disease because they are less aggressive. Apart from that patient, that maybe that one has got a true Crohn's disease. I don't know if you've got an experience with perineal disease, Thomas.
No, I don't have an experience with perianal disease or fistulas in these patients, which is related to inflammation. I have seen it as a complication of surgery, but not as a result of an inflammation. No. So the next one, is there any correlation between the number of defecations per day and IBD? Well, I think when we, as I said, we haven't scoped these patients on a routine basis. I think we would scope patients who have clinical symptoms indicate inflammatory bowel disease and who also have an increased fecal calprotectin, which in some way would mean that they probably have diarrhea or more frequent defecations.
When we started the study, we thought that one of the pathological key point was the obstructive symptoms because of the overgrowth, and therefore we thought that the lower number of bowel movements would lead to a higher likelihood of inflammation. But at the end, when we compared the number of bowel movements in patients with lesions and those without, we did not find any difference. So I don't think it will correlate with the onset of inflammation. That one is difficult.
Question is also on total colonic aganglionosis. How will you manage fecal incontinence at ileal in patients with ileoanal anastomosis? Well, I think for us, in these patients, we usually use loperamide if they have fecal incontinence to try to reduce the hypermotility at least, and we quite often use bulking agents as well, which I think is sometimes quite useful. What do you do? Yeah,
we mostly address it with drugs, Silogel as well, so psyllium fibers, other probiotics, prebiotics, diet. We did deliver a tailored diet, but at the end it's very difficult to deal with an incontinent patient with ileoanal because they do not have a way to clean the distal part of the gut. We try to use the plugs, but they did not seem to work properly. So basically, we mostly rely on drugs.
And the next one is it's a comment. It's a description of a patient who has Down syndrome and total colonic aganglionosis and ileoanal anastomosis, but also an ileostomy, and who actually has an inflammatory bowel disease with granulomas at the ileostomy level. And the comment is that there is not necessarily a link between these findings and the technique of pull-through.
Yeah, I mean, I agree with there is no link with the type of pull-through. And I have to say that those patients with total colonic and Down syndrome are those that represent the most tricky ones, because I wouldn't say all, but most of them will end up with a terminal ileostomy because of the rashes leading to a number of issues that are very difficult to deal with.
Next question is on pouch complications. Do you use a J pouch for total colonic aganglionosis?
No, not a J pouch. I don't even use a Duhamel, but if we compare Duhamel with a pouch, we would use the local anti-inflammatory agents such as azathioprine or steroids in enemas, and antibiotics such as metronidazole, not local but by mouth, and washouts. What do you use in pouch inflammation?
So we used the ileoanal anastomosis with a J pouch for a while, several years ago, but we moved to using a straight ileoanal anastomosis. There has been a lot of discussion about that, whether there is an increased risk of pouchitis, but some centers have reported very good results with using a J pouch with low incidence rate of pouchitis. So I think that both options are possible, and both options can lead to good outcomes.
And do you do 2 or 3 stages procedure?
Well, I think we do usually first an ileostomy, and when we do a straight ileoanal anastomosis, if the patient is doing well, we usually close the stoma at that time. So a two-stage procedure. Doing a ileoanal anastomosis with a J pouch, I think it's reasonable to keep a protective stoma for a while after that, which means that you need to do a three-stage procedure.
Yeah, we do the same. And what about recurrence rate and reduced surgery?
You get a lot of referrals to your center where you see a lot of complex cases where you do, I think, more redo surgery than we do.
Yeah. I have to say that in the past, I've never believed about skip lesions. Then I received 3 patients with total colonic and skip lesion, or at least with a normal biopsy where they did ileoanal anastomosis and 50 centimeters of residual aganglionosis. But still, it is feasible to redo ileoanal straight, provided the anal canal is preserved. So basically, if the endorectal is done properly, you can redo even, I mean, unless there is a short bowel syndrome, you can redo. If not, you end up with incontinence and all the issues that we said in advance.
So it's a question about the surgical technique, and actually among the patients that we follow at our center with total colonic aganglionosis right now, I think there is just one patient who had a verified IBD-like disorder, and that patient had a straight ileoanal anastomosis.
Yeah, in our series comparing those with and without, we did not find differences. But among those who did not have a straight ileoanal endorectal, there were only duomeds, so we did not have any experience of ravine or J pouches. Anyway, nice discussion, isn't it? Jejuno anal.
I think we have some experience with, perhaps, I don't have really an experience with jejuno-anal anastomosis. I have some experience with quite high ileoanal anastomosis, which is sometimes, which puts, I think, the patient in quite a complex and difficult situation with a lot of diarrheas and quite a lot of problems. So I'm not sure about whether we should do jejuno-anal anastomosis. I think it's very, very important to really consider that before and moving forward to that. What do you think?
No, yeah, I agree. I think that jejunostomy mostly implies, as there's no colon, no ileocecal valve, so is a severe form of short bowel syndrome, mostly imply TBN dependence, and therefore, at least in our center, we wouldn't schedule this patient for reconstructive surgery. If you talk about very high ileoanal, yes, we did them. If they are not Down syndrome and a single procedure without anal issues, they have a reasonable chances of having a normal continence. But each time they've got diarrhea and infection or other issues, they will end up in terrible dehydration. So they are tricky patients.
I think there is a question about laparoscopic or robotic assisted surgery. You have experience with robotic assisted surgery?
Yeah, I mean, with total colonic, we did, I think, 3 or 4 patients. And I mean, with the new platform where you can do multi-quadrant surgery, it can be done either laparoscopically or robotically. And I would say that the most important difference is on the endorectal and anal anastomosis, so the preservation of the anal canal and the correct level of dissection from below. If we compare robotic with the laparoscopy, robotic is better when we need to deal with the cuff, when we want to avoid issues during dissection, when we want to preserve the integrity of the perirectal parts and spaces. But at least in my experience, it works perfect in classic Hirschsprung. It works even in total colonic, but in those patients, there are other issues that, in my opinion, are more important than the laparoscopy or robotic approach.
Thank you very much for the attendance. It was really good discussion.
Yeah, I agree. I thank all the audience, and I thank Thomas for his wonderful presentation and his wonderful co-steering.
Thank you, Alessio. Bye.
Thank you, everybody.
Bye-bye.
Good evening.
Thank you.